Hello students, welcome to All About Nursing channel. So today's video is going to about the cardiomyopathy or inflammatory heart disease. So before knowing the different types, you have to know what is cardiomyopathy or what is inflammatory heart disease. So inflammatory heart disease or cardiomyopathy, it involves the heart muscle in which the heart loses its ability to pump blood effectively. So the heart muscle becomes enlarged and abnormally thick or rigid. So what happens in cardiomyopathy? The heart layers, the muscle layers became increased in, there is inflammation in the muscle layer that becomes inflamed, and if there is inflammation is there, so if there is inflammation, that leads to rigidity or that leads to lack of elasticity of the layers of the heart. If there is lack of elasticity, so that leads to, during the systole or the diastole, the systolic function and the diastolic function became impaired. Okay, so before knowing the details of cardiomyopathy, you have to know the behind the cardiomyopathy, the anatomy and the physiology of heart. Okay, so the anatomy of heart, which basically indicates the layer of heart. So we all know the innermost layer is called the endocardium layer, which is made up of endothelium tissue, and the myocardium layer, which is made up of myocyte cells, which is made up of muscle fibers, and which lies in the heart, throughout the heart, by figure of 8 fashion. And the outermost layer is called the pericardial layer, which also has two division, that is inner and the outer. Inner is called visceral pericardium, which has the another name that is called epicardium, and the outermost layer is called the parietal pericardium, which is made up of fibrous tissue. And the visceral and the parietal pericardium, in between that there is a pericardial cavity, a sac which contains pericardial fluid about 5 to 20 ml. That is normal. Okay, so this is the layers of heart. In cardiomyopathy, what happens? The layers, mainly the myocardium layer, become inflamed. There is a dilation in the ventricular site, inflammation of the layers, and that causes the rigidity and decrease elasticity of the heart. So the physiology, that we all know, physiology means the function. So due to the cardiomyopathy, what happens in heart function? So due to the cardiomyopathy, the mainly three functions, that is preload, afterload, and the contractility, these three functions became impaired. First is preload. You all know preload is the stretch, the amount of stretch of the heart muscle layer at the end of the diastole, that is called preload. So the amount of stretch, so that is called the preload. Okay, so if there is increase in the amount of stretch during the end diastole, that leads to increased force of contraction in the systole. Okay, that is basically called Frank Starling law. And next is the, so preload became decreased because of, there is inflammation is there is decreased contractility, that causes preload is, the stretching ability of the heart became decreased, and the elasticity became decreased, so that causes poor contraction. Okay, next is the contractility. So contractility is the strength or ability of the contraction. Okay, force of contraction, that became also decreased because of rigidity of the layers. And the afterload is during the systole, so the ventricles has to overcome the pressure of the aorta, so that uh, the left ventricle has to overcome the pressure of the aorta, so that the aortic valve can be opened. Same, the right ventricle has to overcome the pressure of pulmonary artery to open the pulmonic valve. So afterload is called, the ventricles has to, the amount of resistance that has to overcome by the ventricles during the systole to open the valve, that is called, to open the valve and to eject the blood to the aorta, so that is called the afterload. So that also became decreased. Okay, so the types of cardiomyopathy, there are three types: dilated cardiomyopathy, hypertrophic cardiomyopathy, and the restrictive cardiomyopathy. Okay, so the dilated cardiomyopathy, we will discuss it. So in the picture you can see easily there is three types of cardiomyopathy, dilated, hypertrophic and restrictive. So in the picture by which you can easily understand that normal heart and the dilated. So you can see that the name suggests that there is a profuse dilation in the heart structure. So the ventricles become profusely dilated. You can see from the normal there is a dilation in the ventricles. In the hypertrophic, the septal wall became inflamed. So hypertrophic in name suggests that there is a hypertrophy. Hypertrophy means the cellular size became increased. So the cell size became increased in the septal wall. And the restrictive, you can see more or less same in structural. There is no structural changes, but the functional changes became happened. So dilated cardiomyopathy, what is dilated cardiomyopathy? There is a dilation, I already told. There is diffuse inflammation in the ventricular wall, ventricles, and the rapid degeneration of the muscle fibers, the myocardial fibers. Myocardial muscle fibers become degenerated, lost its ability, elasticity, and that causes rapid degeneration, and there is a diffuse inflammation. There is an increased size, cavity size, you can see in the picture easily, and the weight also became increased in the dilated cardiomyopathy. The normal heart, this is the dilated heart cardiomyopathy. So what are the causes? So the causes are, first is cardiotoxic agent, that is alcohol and cocaine. So cardiotoxic agent, what happens when we consume the cardiotoxic agent continuously? So cardiotoxic agent irritate the cardiac cells and tissues. When there is continuous irritation of the cardiac cells, that leads to generation of the inflammatory responses. So there is a inflammation. Next is the coronary artery disease. So due to the coronary artery disease, there is a ischemia in the cardiac cells and tissues. There is a necrosis, and that causes generation or stimulation to the inflammatory response. The genetic, if there is a hereditary history is there, so that can lead to further offspring, lead to development of cardiomyopathy. Next is the hypertension. So in the hypertension, what happens? So in the hypertension, so there is an increased pressure or the resistance in the aorta. In the hypertension, what happens? There is an increased peripheral vascular resistance, as well as there is an increased resistance in the aorta. So the left ventricle has to work harder and contract harder to overcome the resistance of the aorta, so that it can open the aortic valve to eject the blood. So the ventricle has to continuously work harder to overcome the resistance in the aorta, because in the hypertension, we all know there is an increased resistance. So the ventricle has to work harder to overcome the resistance. So if there is increased workload in the ventricles, that causes inflammation or in the structural changes in the ventricle. Okay. So that leads to cardiomyopathy. Next is the metabolic disorder, like different diabetes mellitus, hypothyroidism. So different disease conditions are there that can lead to also the dilated cardiomyopathy. The muscular dystrophy, so like it is an autoimmune disease where there is degeneration of the muscle fibers is there. So that can lead to cardiomyopathy. And the myocarditis, infection and inflammation of the myocardium due to the pathological condition. Next, coming to the pathophysiology. What happens due to the etiological factors that leads to decreased contractility of the heart. When there is decreased contractility, the body's compensatory mechanism, the ventricles became dilated to increase the contractility. So to maintain the cardiac output, ventricles have to maintain the cardiac output, so that the ventricles started to compensate the condition by increase its contractility. By which? By stretching the muscle fibers, by stretching its wall, ventricular wall. So when there is stretching in the ventricular muscle fibers, that leads to increased ventricular radius. There is an increased ventricular size, and if there is increase in size, so that leads to increase in wall tension. When the size became increased, when the balloon became inflated. If you give an example, if you thought an example like if a balloon, when you push the air into the balloon inflamed, or it became full with the air, and if you see the layer of the balloon, it became thin, it became stretched. Maximum stretching is there, maximum wall tension is there. Likewise in the heart, if the ventricular size became increased, so there is increased wall tension in the heart. Wall tension became increased, pressure became increased. So that leads to there is increased demand of the cardiac cells. So cardiac cells became working harder, there is increased workload, so they need more oxygen, more nutrients. The cells needs more oxygen, more nutrients. so there is increased demand. So the demand is not fulfilled, so that leads to cardiac output become fall down, and that leads to the symptoms, sign and symptoms we can find that if there is decreased cardiac output, that leads to the symptoms we can see, like there can be dyspnea, there can be orthopnea, there can be the decreased peripheral perfusion, decreased capillary refill, there can be decreased pedal pulses. And the signs we can see, that is decreased abnormal S3 and S4 sound because of turbulent blood flow in the ventricles, and we can see dysrhythmia, abnormal rhythm of the ventricles, and heart murmurs, abnormal heart sound because of turbulent blood flow, as well as the valvular stenosis, and the pulmonary crackles due to the pulmonary edema, because if there is stasis of blood in the ventricles, left ventricle, that causes stasis of blood in the pulmonary circulation. If there is stasis of blood in the pulmonary circulation, that leads to increased capillary permeability, and if there is increased capillary permeability, that leads to pulmonary edema. If there is pulmonary edema, that leads to pulmonary crackles. Okay, we can hear the sound, that is pulmonary crackles. Next, the edema, peripheral edema we can see, because if there is stasis of blood in the right ventricle, that causes decreased venous return. If there is decreased venous return, that leads to stasis of blood in the vein, and that causes increased capillary permeability, same, that causes edema in the periphery. Then weak peripheral pulse due to the lack of circulation, that causes weak peripheral pulses in the extremities. Then the pallor due to the lack of circulation. Then the diagnostic test we can find, that is we can do the Doppler echocardiogram, where we can find that dilated cardiomyopathy, or the chest X-ray, we can do the chest X-ray, where we can find the balloon shaped heart. Okay, you can see the heart became inflamed, dilated, and it looks like balloon. Next, the ECG revealed that sinus tachycardia, abnormal rhythm. Okay, and the poor R wave progression. Why poor R wave progression? Due to the poor ventricular contraction. We all know the R wave basically generate the peak is of the QRS complex is R. So that is due to the effective ventricular depolarization. If because of dilated cardiomyopathy there is decreased ventricular depolarization, the contractility become decreased, so that the R wave amplitude in the inferior wall, you can see in the ECG graph, the R wave amplitude is decreased, small R wave, due to this. Next, the management you can do, that is vasodilators to improve the circulation of blood to the coronary arteries in the cardiac cells. Then the furosemide to decrease the workload of the heart, to decrease the volume. Next, the metoprolol, beta blocker, beta 1 adrenergic blocker, selective cardiogenic drug we can give to maintain the rhythm of the heart, mainly the rate of the heart. And the amiodarone we can give to, it is a class 3 anti-arrhythmic drug, where it basically it do to maintain the normal rhythm. Okay, and other management like ventricular assisted device, that is LVAD, RVAD, we can use to maintain proper effective cardiac output. Cardioverter defibrillator to maintain the normal rhythm, to decrease this, to combat with the dysrhythmia, we can use the cardioverter defibrillator. And the heart transplantation at the last of management to maintain the normal cardiac functions. Okay, so other types of cardiomyopathy will be discussed in next video.